there are multiple fracture feeling, and this patient age was 80 years when he reported to me. But if you see, the patient was repeatedly doing this fractured feeling at the interval of 6 months. Now, when he visited to me, I focus on the problem. So, and then I focus why it is happening. So, whenever the such situation is reported to your clinic, first you focus why it is happening in the patient's mouth, and then you focus on the treatment. Now this situation where you can see the feelings everywhere, and there is a loss of anterior guidance, interference in the back side. So such situation, before starting the treatment, you focus on why it is happening with the patient. And this patient was having the internal disarrangement with reduction. So first we need to stabilize the TMJ, and then you focus on the treating the teeth. This situation, these are the difficult situation in the clinical scenario where you can see class 3, um, like a class 3 type situation, anterior crossbite, and posteriorly there are the missing teeth. So here deprogramming, in such situation, deprogramming will help you a lot. So first you focus on the problem and then on the treatment. So this situation is a tough situation in a clinical practice where deep bite is there due to loss of vertical dimension. So deprogramming will always help you to stabilize the TMJ, followed by the definitive treatment plan. This is again difficult situation. The deep bite is there. You can see cervical areas, fraction and the caries. Okay, so first you need to focus on why this is happening, because if the natural teeth are falling down, natural teeth are breaking down, then your restoration is the same way we may break if you are not focused on the etiology. This was the this patient, you can see the fractured enamel, fractured ceramic layer, okay, of recently done full mouth rehab. So you need to focus why it is happening. So sometimes the implant may fracture, and most of the time what happens, so you don't know why it is happening. So why my restoration or why prosthesis is fracture, in spite of using the best material, best skill and time, patient and doctor both get fed up as there is a wastage of time and the money, and we try to do more and more on the teeth only, but we don't focus why it is happening. So in such cases, diagnosis of the problem is very important, as it may lie into the masticatory apparatus. Now, what is masticatory apparatus? So we dentists are not only doctors for teeth and gums, but we are also physicians of the masticator system. And this design of the masticator system includes TMJ, that is temporomandibular joint, muscles, ligaments, and the teeth. And teeth are the component of the masticator system. Whatever treatment we do, it should be with respect to the masticatory system or the masticatory apparatus. So why it is important to understand TMJ and the occlusion. If you see TMJ, it is having teeth, muscles, and the joint. TMJ, temporo, teeth, muscles, and the joint, and the base is formed by the joint. So base should be always strong. So if the teeth are not in equilibrium with all other parts of the total system, something is likely to break down. This is in the Peter Dawson preface. If you see this ceiling, Mumbai ceiling, it is having the strong base, so it is durable. If you see the aesthetic one or aesthetic restoration and the base is weak, this is not going to stay in. This is not going to stay or durable in the patient's mouth. So the design of the masticator systems require a balanced equilibrium of all the structure to maintain its stability. So if you say one of the tire of the four wheelers is worn off or is not good, so it will affect the other three tire and engine performance. Same way, if the out of the four components, if one component is affected, it will affect the other three components. So neuromuscular harmony depends on structural harmony between the occlusion and the temporomandibular joint. So according to Peter Dawson, dentists who ignore the TMJ can never be competent in smile design or diagnosing or treating occlusions. Dentists who ignore occlusion can never be competent in diagnosing or treating problems of TMJ. So to conclude, as per the Peter Dawson, we cannot ignore TMJ and occlusion principle while treating our cases. If you know this in advance, we can discuss with the patient before starting the treatment and prevent future treatment complication. Now, what happened most of the time, we start the treatment, and after finishing the treatment, patient may complain of the TMJ pain, muscle pain, or a click in the joint that was previously present, but we are not examining it, or we are not seeing it, or we are not told to the patient. So whenever we finish the patient, if that existing symptoms precipitate, patient may say, after doing your treatment the symptoms are precipitate, so they may blame you. So before starting any treatment, even before starting any filling, extraction, orthodontics, FMR, implant, first you examine the TMD, TMJ and muscles of mastication, let the patient know the status, and then you start the treatment. So in this presentation, I am giving you the simple way of examination of the TMJ. So one by one, while doing examination, you can come to the diagnosis of the TMDs. So these are the simple methods I am going to teach you in this presentation. So if you see the TMJ, TMJ is having head of condyle, then articular disc, okay, and posteriorly there's a retrodiscal tissue. So this is a stable joint. This is in the sagittal section, and this is the coronal section. This white portion is the disc, you can see, and below the disc is the joint space, inferior and the superior. Now when the teeth are into occlusion, the TMJ we want in this stable position. Some say it is a musculoskeletal stable position, some say it is a centric relation, but it is in this position. TMJ can take a maximum load during mastication. So this is very good position. We want to achieve this position during or before proceeding for any definitive treatment in the patient's mouth. So range of mandibular movement, you can measure this distance in interincisal distance from upper central to lower central incisor. This should be maximum up to 40 to 60 without any pain. Then the lateral movements, you mark the midline and ask the patient to take the jaw to right and then to the left. This should be the 10 millimeter at least without any discomfort. Then protrusive movement should be 10 to 14 mm. And when patients open the mouth, there should not be any deviation and the deflection. Now, what is deviation and what is deflection, and what does it indicate? So you mark the midline and ask the patient to open the mouth. Suppose here, this is red marking, the patient is taking the jaw to the right, and on full mouth opening, the midline is again coinciding. So this phenomena is known as deviation. And if the patient is having this phenomena or deviation, then it indicates patient may be having either a myofascial pain or internal disc derangement with reduction. Okay. Now, suppose the patient opens the mouth. You can see this situation where deflection, where the patient opens the mouth and the mandible remains one side on the full mouth opening. Okay, so it is not coming to the again to the coinciding with the midline. This phenomena is called deflection, and if the deflection is there, then it suggests to the patient is having internal disc derangement without reduction. So both the term I am going to explain you in the later part of the presentation. Now, if you see here, the if you are walking on, now it is a rainy season, and if you see there's a lot of potholes on the road. So this is, if it is small pothole on the road, you'll just change your path and again coming to the midline. So small defect, that is myofascial pain or internal disengagement with reduction, you will get the deviation. And if the road is full of potholes, you cannot walk on the same road. You will walk on the side of the road like this, and you deviate your jaw to the one side. So this is the big defect, is a deflection, and you will get this defect in case of, or this phenomena in case of internal disengagement without reduction. Now again coming to the clinical examination, how you palpate the temporomandibular joint. There are two methods. One is the intra auricular method and one is pre-tragus method. And again, you need to check the joint sound. So here I'm going to show you the video how you should examine the temporomandibular joint. Now we'll demonstrate you how to examine the temporomandibular joint. There are two methods. First is the pre-tragus method, and the second one is the intra-auricular method. Now in the pre-tragus method, you just place one finger and now ask the patient to do opening and closing. Opening. You should feel for any joint sounds, or you should slightly palpate the area, use some firm pressure, slight firm pressure to see any tenderness over the joint. You can also see the movement of the head of condyles going in which direction. Now, next examination is the intra-auricular area. You can a small finger, you can palpate, and you press against the anterior wall of the on the both the side, okay, and you ask the patient to open and close. Open, close. You can feel the head of condyle, okay. If any clicking sound or any other sound is there, as well as any tenderness, as well as you can see the movement of the head of condyle. So ideally you should stand in front of the patient but for the demonstration purpose I'm standing behind, and this is a very good method, intra-auricular method. You can feel and you can feel the position of the TMJ during bite also and during occlusion. It is excessive overclosure or underclosure. You can see with this method. In this video I'm going to show you the how the click is audible, and patient is deviating the jaw, can deviating from the midline, and you can hear the click in both the joint. So suppose you are getting the deviation and you are getting the click. So what is your diagnosis of the TMD is disc displacement with reduction, click and the deviation. So now we'll see how the joint works, how the disc works. So this video is a normal TMJ showing the disc. This is a bow tie appearance is the disc, and this is a head of condyle. This is the what? The articular eminence. Now when the patient opens the mouth, so you can see movement of the disc, anterior band, intermediate zone, posterior band, retrodiscal tissue, and this is the superior lateral pterygoid is attached here. Okay, you can see the movements. On opening, the disc is coming below the head of condyle, and both are working together. Okay, and when patient close the mouth, so this is a stable position. Okay, this centricalization or musculoskeletal stable position you say, and when you open the mouth, you can say what? The bow tie appearance. Though this appearance on MRI, you can see, if you see this appearance on mouth opening, then on MRI you can say the disc is normal. Now if you see the other video, disc displacement with reduction, here you can see disc is anteriorly displaced. Okay, and when patients opens the mouth, you can feel the snap. Okay, you can just see here snap. Okay, this will create a sound, clicking sound. Okay, so normally many dentists and many people say the click is normal. Suppose a click is normal, then every joint should give a click. So click is not normal. Click is a abnormal thing. Okay, and thus there is a need to treat a click. Yes, there is a need to treat a click. Click is a disc displacement with reduction. So it is better you should treat as early as possible, because if you're not treating it early, the progression of disease will happen. Okay, now again you can see here is some sound here. Carpenter is doing some sound. So it is a long grating sound, and same sound you can hear here. So this is long grating sound is a crepitus, and you'll hear this sound in case of osteoarthritis. Now, clinical examination of the muscle is very important. With the help of clinical examination of the muscle, you'll come to know the patient is having myofascial pain or not, or we can say the muscular TMD. Okay. Now, what you're checking with the help of clinical examination of the muscle, you are checking the trigger point, is a sore point. Once you press that sore point, the patient may jump from the chair. It is known as jump sign. Okay. Like this patient may jump is known as jump sign, or patient feel a very painful reaction. Patient will give some painful reaction. Now examination of the temporalis. This is big fan shaped muscle is a temporalis. It is having anterior, middle and posterior belly. Now you ask the patient to clench the mouth, okay, and do the protrusive movement. So you feel the muscle. Once you feel the full length of the muscle, then you can palpate it. And most of the time what happens, there's a misconception in many patients mind. If the headache is there, they say this headache is a migraine. So on pressing this muscle, if there is a pain in that muscle, means tenderness of that muscle, so that patient is not having the migraine. That patient is having MPDS or myofascial pain, because MPDS is due to the muscle and the migraine is due to the, it is a neurovascular origin. or we see in the classification. This masseter muscle, so how to palpate? Just this you can see, ask the patient to clench, and you can feel the masseter muscle. You can palpate it superiorly and the inferiorly. Then medial pterygoid muscle from at the angle of the mandible. And most of the time when the patient complains of the pain in angle of mandible, most of the practitioner feel it is the pain is due to the third molar or pain is from the throat. Lateral pterygoid, we cannot directly palpate the lateral pterygoid, so you need to do some movement, protrusive movements. Ask the patient to do protrusive movements and just resist that movement. If patient feel pain in the TM joint area, then that lateral pterygoid is tender. I'm going to show you some videos of examination.
Hello everyone, now I am going to show you the demonstration of how to examine the muscles of mastications, neck and back muscles, muscles of the upper limb and the lower limb, as well as the muscle examination of the temporomandibular joint. Now first to start with the muscles of mastication examination. Now before starting any examination of the muscle, first you should know the entire length of the muscle so that you can palpate it properly. So you first ask the patient to do that proper movement so that you can palpate the entire length of the muscle. So first we'll start with the temporalis muscle. Now you ask the patient to open and close the mouth. Okay. So once the patients open and close, you can feel the muscles here. Now temporalis having the three bases, anterior, middle and the posterior. When patients opens the mouth, you can feel the anterior and the middle belly. When patients protrude the mandible you can feel the temporalis. Okay. Now you should examine the muscle for the any sore point or tender point, or also known as the trigger point. Okay. Now this is the complete temporalis muscle. Okay. Then the muscle comes the masseter. It starts from the zygomatic area till the inferior border of the mandible. Now you ask the patient to clench the mouth. So once the patient clenches the mouth, you can feel the muscle. Now you should give a slight firm pressure so the tender point is there, you will come to know. The next muscle is the medial pterygoid. Now medial pterygoid, it starts from the inner aspect of the mandible and it goes to the pterygoid plates. So you can palpate in this area for the medial pterygoid. There is also a lateral calcium later on. The next now we'll start with the examination of the lateral pterygoid muscle. We cannot palpate the lateral pterygoid directly, so you ask the patients to protrude the mandible like this and then you resist that movement. Okay. So if there's a pain in this area, it suggests the lateral pterygoid is tender. Now you again ask the patient to do side to side movement. So if any tenderness is there, we'll come to know. Second, next muscle is the medial pterygoid. Medial pterygoid you can also palpate intraorally as well as extraorally. Extraorally here, you again ask the patient to do a side to side movement. So you can palpate the muscle. Okay. Intraorally you can palpate the medial part of the mandible.
Okay. So after examination, we can see if the tenderness of the muscle of mastication is there. So we can tell the patient, just say from 1 to 10, how much is the pain, and you record that pain score. So we'll come to know how tender are the muscle, and we from that we can diagnose the myofascial pain or MPDS, and then same score can be useful or utilized the post treatment also. How much the reduction in the pain score is there or VAS score is there. So next is the imaging. So for the bony component, we can ask the patient to for the CBCT, conventional radiography or the CT scan, and for the disc, MRI is the best. So conventional modalities, transcranial view for the joint space. Most of the people have OPG. They can advise for TMJ view on OPG, then transorbital view and the transpharyngeal view. Then OPG, if you want to see the teeth and the joint, so ask the patient to go for a closed mouth OPG. What you need to do in this, instead of incisal tap, you ask the technician to remove the incisal tap and ask the patient to close in MIP and take the OPG. So this is closed mouth OPG. This is very useful. You can see both the things together, the teeth as well as the joint space, and this will be very helpful before the treatment, during the bite of the patient, and temporization and full mouth rehab. So this is very good radiograph. You can start taking this radiograph even before starting the ortho treatment also, to evaluate the temporomandibular joint, because most of the time we don't evaluate the temporomandibular joint and we start the treatment, and then after that we land up in the problem. Okay, so every time before starting any big treatment, first go for clinical and radiographic evaluation of the temporomandibular joint. Okay. Now, whatever the radiographic joint space you see on the radiograph, it is known as radiographic joint space, and it includes this 9 component into it. So on the CT or CBCT, this is the axial view. You can see what you need to check for. You need to check for the cortical outline. So if the cortical outline is good, there is no break in the continuity, and it is there everywhere. So we can say it is a normal head of condyle. Okay. This is in the axial, this is in the coronal section. You can see here. And this is the medial pole, lateral pole, and the cortical outline. So it is a normal one. This is the sagittal. This is articular eminence, head of condyle. You can see good. And the radiographic joint space here. So radiographic joint space in the center is 2.5 to 3 millimeter. In the front is 2 to 2.5 millimeter. Posterior is 2 millimeter. If the reduced joint space is there, it suggests the disc displacement, and there is a chances of the osteoarthritis is started if there's a loss or flattening of the this bony or osseous component. And this, if you see this, this is the MRI. MRI is totally, and if you see the CBCT and MRI, the appearance of the MRI is totally different. What appears radio opaque on the CBCT will be appear radiolucent on the MRI. But beautifully, you can see the disc here. You can see the disc here on the MRI. This is the external auditory meatus. This is the disc, and this black is the cortical outline of the head of condyle, and these are the muscles. Okay, you can beautifully see on the MRI. This is the sagittal section, and this is the closed mouth one. When you ask the patient open the mouth in the MRI, on mouth opening you can see this bow tie appearance like this. The most of the old heroes used to wear the bow tie in the old movies. So bow tie appearance is there on mouth opening, suggestive of the normal disc on the MRI. This is coronal section showing the disc. This you can see the medial and lateral. If the disc is medially or laterally displaced, this is the lateral part, this is the medial part. But beautifully you can see the disc here. Okay, and this is the brain, is very close. So that's why the god has made the neck of the condyle weak to prevent the brain injury. Now if when the patient open and close the mouth, you can see the disc movement. Same way you can advise for the dynamic MRI or the pseudo dynamic MRI, and in that you can see the same movement here. You can see the here bow tie appearance of the disc, and movement of the muscles also can be seen. Now most of the time it is very difficult to tell the patient is having occlusal interferences. But if you take this good cheek retracted video of the patient in the closed mouth, protrusion and the laterogen, you can see the lot of interferences in the protrusion or the laterogen. So you can see here the interposterior interference. Same video is very useful to you as well as to the patient. So to show the patient is having interferences and the pre and post treatment evaluation. So you can see for the curve of P or curve of Wilson is proper or not. And many people feel third molar, if the curve of P is very stiff, then third molar create interferences. So again, interferences is the cause of TMD. It is the most common etiological factor of the. We have done the study on it, and we found that interference is the most common etiology in the TMD. Then anterior and the canine guidance. So you can see, we have seen if the posterior interference is there, then anterior canine guidance is not there. Okay. So how to check the anterior canine guidance? You can take blue or black articulating paper, 40 micron most probably, and tap ask the patient. You can mark take the centric markings and take the red marking papers. So ask the patient to close and protrude and do side to side movement. If you are not seeing any red marking on the posteriors, then the patient is having no interference in the posterior and only red marking in the front. So patient is having good anterior canine guidance. If you see any red marking on the back of side of the teeth, back teeth, then that tooth may be giving interference in the protrusion or the lateral movements. So coming to the most important part of this presentation is TMD diagnosis. So this is the chart I made for you people. So you can click a photograph or screenshot of it, and this can be useful for your diagnosis, orofacial pain diagnosis, TMD diagnosis for your patient. So this is from the Bell's orofacial pain textbook. So if you see, most of the time when the patient is coming to you, you need to differentiate between different types of pain. First is the primary dental pain, and we easily differentiate between them. Suppose patient is having caries, pulpitis, periodontal pain, so we can easily diagnose them, but difficult is the referred dental pain. So what is primary dental pain? Suppose the patient is having caries and the same tooth having a pain, that is a primary dental. So source and site as the uh, same same place. Okay, so you can easily differentiate it. But if the source and site is different, so then the diagnosis becomes difficult. Suppose patient is having the toothache, but the origin of that toothache is lies somewhere else, maybe in the muscles. Suppose most of the time temporalis, from the temporalis the pain referred to the anterior teeth, and we check for the anterior teeth, there is nothing, and we take radiographs, we try to tap the patient, there is no tenderness, nothing. And then in that, what you start doing, the root canal, and still the pain persists, means the patient is having the referred frame pain from the other part of the or other structures, so mostly from the muscle. So suppose in temporalis, if you palpate and there is a pain increase at the site, that means the pain is referred from that muscle to the tooth. That way you can diagnose it. And most important is the orofacial pain. So it is called axis 1 orofacial pain, and axis 2 is a psychologic conditions. We are not concerned with that. Okay, the axis 1. Now in axis 1, so orofacial pain is broadly classified into musculoskeletal one, neuralgic, neurovascular, and the vascular. So if you see the TMD is a musculoskeletal type of pain. So TMD is also one of the orofacial pain. Then neuralgia, everyone is well versed with the neuralgia like trigeminal neuralgia. Okay, so trigeminal neuralgia, the pain is episodic, means pain आता है, break होता है, फिर से pain आता है. They are in the episode and they are very sharp shooting type of pain. And in trigeminal neuralgia, you get a trigger zones. In case of TMD, you get a trigger points and it is a dull continuous pain. Then neurovascular pain is a migraine. I told in the beginning, there's a lot of difference between the migraine and the TMD. TMD is a musculoskeletal pain. Suppose you press or check, examine the muscle, there is a pain, it is a musculoskeletal. So it is a TMD. And migraine pain is a neurovascular. So etiology is different. Then again, other type of pain are vascular, like a temporal arteritis. So in this way, you can differentiate the pain. You keep this chart in your clinic and you easily can differentiate, or for more details, you can refer the Bell's orofacial pain textbook. Okay, this is the classification of the temporomandibular joint disorders given by Schiffman et al. Here you can see lot of the TMJ are having the lot of disorders. Their classification contains a lot of things, but and we can see joint diseases, joint pain, masticatory muscle disorders, and in that there is a movement disorder, orofacial dyskinesia, oromandibular dyskinesia, dystonia, sorry, dystonia. So all this comes under temporomandibular joint disorders. So, but according to the TMD research diagnostic criteria, TMD is classified into the three groups. Okay, according to the common factors among conditions, other TMD disorders which are uncommon or have no reliable criteria or examination methods are excluded. So TMD IDC groups are group 1, group 2, and group 3. And again, this criteria is modified by in DC TMD criteria. Okay, so what is this criteria? This is if the muscle is involved, is a myofascial pain. So that's why muscle examination is very important. You can diagnose it is a muscular TMD only or is intracapsular TMD. Then disc displacement. If the disc is involved, I told you, if the clicking is there and deviation is there, it is a disc displacement with reduction. And if the patient gives history of clicking, there is no click right now, and there's a history of clicking, and deviation is there. This is a disc displacement without reduction. And third one is the, if the articular surface or the bone involvement is there, it's the osteoarthritis. So simply, according to the DCTMD criteria, TMD is classified into myofascial pain, disc displacement with reduction, disc displacement without reduction, and the osteoarthritis. Okay. So coming to the etiology of the TMD, everything starts with the myofascial pain. So this is the etiology of all the TMD. Everything starts from the myofascial pain that goes to disc displacement with reduction, without reduction, and the osteoarthritis. So what is the etiology for this? So most of the people, they say it is the stress. Yes, stress may be in the form of emotional, mental, or physical, leads to the oral habit. So it is one, you can say, precipitating factor. But the patient is having the abnormal occlusion, maybe in the form of deep bite, cross bite, open bite, class 3 malocclusion, class 2 malocclusion. So that again, the abnormal occlusion, that again having a lot of interferences. So these patients, and again the restoration, if the patient is having restoration and that are having a lot of interferences, all this thing will lead to the oral habits, maybe in the form of bruxism or clenching. If the patient is having a lot of interferences and stress also, so everything, a patient every day is doing the bruxism, clenching, and leads to the muscle fatigue. Muscle fatigue will lead to the myospasm, and myospasm lead to the myofascial pain dysfunction syndrome. We can see here, lead to occlusal dysharmony, altered chewing function. Altered chewing function lead to the again occlusal dysharmony, degenerative arthritis. So it's a vicious cycle then. So one thing lead to another thing. But when the patient is reported to us, that time there is a lot of things might have happened in patient's mouth, like a occlusal disharmony might have happened, and we say it may be the patient is having, or patient occlusion is like that, but whatever we see, it is an adapted occlusion in the patient mouth. So history way is very important before you start the treatment. And TMJ, that's why the TMJ examination and muscle examination is very important. This study we had done in the department in the college, and we found that most common occlusal etiological factor in the TMD is the occlusal interference. This is a clinical presentation of the myofascial pain. So patient may be having a dull unilateral pain in the ear or the preauricular region. Pain is worse on awakening, tenderness of the muscle of mastication, and limitation or deviation of the mandible on opening. These are the classical feature of the myofascial pain, but patient may be having bilateral pain also. And this pain is dull and continuous. In case of trigeminal neuralgia, pain is sharp shooting and it is intermittent. The differentiating factor and the trigger points in case of myofascial pain, and trigger zone in case of trigeminal neuralgia. So how to examine the muscle of mastication, I already explained to you. Okay. Why it is difficult to diagnose myofascial pain? I already told you it is a referred pain. So due to the referral nature of the pain, is difficult to diagnose, and patient complains of pain in different various part of the body, ear, jaw pain, shoulder pain, neck, back pain, and patient is confused where to go. So depending on the symptoms, patient go to the respective specialist. Now this is the very important slide. We can say the medial pterygoid pain is referred to the posterior part of the mouth, throat, TMJ, infraauricular area, eustachian tube. Okay, so we feel suppose this patient go to the ENT and they see there is nothing. Why there is a pain? Because it is a referred pain. Okay, same the lateral pterygoid pain referred to the TMJ and the zygomatic area. So if there is a pain, there is nothing there. So patient, whichever the specialist patient go, they say it is normal. Then most of the time they feel patient is not telling it properly, or misleading the dentist or to the physician. Then from the masseter is referred to the posterior mandibular maxillary teeth, jaw, ear, upper portion of the face. And most of the time this patient complains of tinnitus. So tinnitus is ringing in the ear. So one of the cause of the tinnitus is the masseter hyperactivity. So we can also treat the tinnitus if the reason is due to the masseter hyperactivity. Then I told you this from the temporalis, the pain refers to the upper anteriors. So in such cases, if you do anything to the tooth, the pain doesn't resolve. So in this, if you treat the hyperactivity of the temporalis, the pain in the tooth will go. So diagnosis is very important before you start the treatment. Otherwise, you will end up in doing the root canal extraction, and still the pain will be continuously there. So the patient visit almost all the medical specialists and clinic to clinic in search of the cure, but no relief in their pain. Like this, all the specialists they are going. So progression of the TMD, from I told you, from MPDS it goes to the disc displacement. What is disc displacement with reduction? So you'll get click. Why do we get a click? So disc is displaced anteriorly and patient opens the mouth, the head of condyle hits the disc and you'll get a click. Now again this is the normal position, again while going back again get a second click. So you get opening and closing click known as reciprocal click, and you get a deviation. So if these things are there, clinically you can diagnose it as an internal disarrangement with reduction. Etiology is again MPDS, macro trauma and micro trauma. Next progression of the disease, if you are not treating the disc displacement with reduction and if patient is not coming to that level, the patient may land up into the disc displacement without reduction. So here the patient will give history of click, okay, and uh, what happened when patient tries to open the mouth, the head of condyle gets stuck by the disc and the mouth opening may be limited. This is a very tough situation to treat. Many times if you cannot treat it non-surgical way, then most of the time is mouth opening is limited, then you need to go for a surgery also. So here you can see limited of the mouth opening in anterior disc displacement without reduction. Limitation of the, and osteoarthritis will start here. Okay. So next progression is the TMJ osteoarthritis. This is a 22 years old female reported to me, and she advised surgery, but they don't want to go for surgery. And she was having history of click 5 years back, but no one told her about the treatment. So she land up into the osteoarthritis. You can see here head of condyle here and is flattening. This is head of condyle as a flattening. Nearly the 60 to 70% head of condyle is gone. So this is a beautiful slide showing myofascial pain progression, and this is the internal disarrangement. Sorry, and then internal disarrangement with reduction, without reduction, there will be history of click. Here in this displacement with reduction, patient will give a click. Here history of click, and it will lead to the osteo. So if suppose you are not treating the patient at this any but point of time, the patient may land up into the next level of the disease. So it is very important to diagnose the disease at particular level and treat it. If you are not able to treat or diagnose, so send the patient to the specialist, and you can do a very good thing for the patient by helping the patient. So in every patient, there is a need to examination of the masticator system, need to consider TMJ and occlusion before proceeding for FMR, orthodontics treatment, implants and implant restorations. In occlusion, you need to check for occlusal contacts, anterior guidance, canine guidance, occlusal curves, and the occlusal interferences. Coming to the management of TMD, so pharmacological management, most of the time we give muscle relaxant to the patient, then trigger point therapy, physiotherapy, counseling. So this already everyone is doing. Then most commonly used are the soft splint, then vacuum form hard splint with unstable occlusion, and the guidance is we give it to the patient, okay, and patients walks away without definitive treatment plan, and we feel that the patient is cured. No, he's visiting clinic to clinic in search of cure. There is no cure for the patient. Why? Because we are treating the symptom, not the etiology, and etiology lies into the occlusion. So occlusal splint therapy is very helpful in such patient. It is both diagnostic and prognostic and reversible. So diagnostic, with the help of this, if the patient symptom reduces, is diagnostic. Prognostic, if the with the splint the patient get relief. The same way, if you do the definitive changes in the patient's occlusion, the patient will get relief. And reversible. So suppose patient don't want to proceed, or if nothing, patient don't want to proceed with the therapy, if the patient doesn't wear it or remove the splint, the occlusion will be as before as it is. Okay, so that's why it is a reversible. So purpose of all the occlusal splint is peaceful neuromusculature. So there are various types of splints, various classification, and there's the deprogramming splint. The purpose of the occlusal therapy is peaceful neuromusculature. Okay, Types of occlusal splint: permissive splint, in that anterior deprogrammer is there, anterior tension suppression system, and full coverage occlusal splint. And in directive occlusal splint, anterior repositioning splint. What is the difference between permissive and the directive? So permissive is having opposing flat surface, is allows the movement of the opposing jaw, means mostly the lower jaw. And directive splint will not allow the movement of the lower jaw. It will fix the jaw in a particular position. So why and where and why occlusal splint therapy can be used? If an occlusomuscular disorder can be resolved by occlusal splint, it can be resolved without a splint by a perfect occlusion with tooth-to-tooth contact. So useful for pre-treatment outcome. So it is both diagnostic and prognostic. Both dentist and patient becomes confident about outcome of the treatment. Patient wins dentist confidence in successful treatment, and most of the TMD cases require full 4 hour if the patient want to go for a definitive changes in the occlusion. And if like this 4 hour reshape, that is occlusal equilibration, reposition is orthodontics, rebuild is ortho restorative dentistry, and resect is a orthognathic surgery like in a class 2 class 3 cases. Okay, so 4 hour. Then if the patient doesn't want to continue, most of the TMD cases require 4 hour. But if the patient doesn't want to go for definitive, then patient can continue with the splint therapy lifetime with the recall, periodic recall of the splint. Then this is a beautiful table I made for the treatment planning. These are different procedure like a deprogramming, occlusal equilibration, orthodontics, diagnostic wax up, temporization with tooth and prep, temporization without teeth and without tooth prep, with teeth prep, final restoration, full coverage occlusal splint, recall water flosser, recall every 3 to 4 months, clinical examination, imaging. So this are all the procedure we are doing in case of the full mouth rehab cases. And what we need to do in cases the patient is having the TMD like a displacement with reduction, without reduction, then in that cases the complete reprogramming is required till all the patient symptoms go. Then and then only you can proceed for the definitive. You should not proceed till that period of time for the definitive treatment. And the patient is having just myofascial pain, there is no intracapsular TMD, then limited period of deprogramming is okay, and then you can proceed. But I want to tell you, for every cases like in orthodontics also, deprogramming is very important before you proceed for the treatment. It will reduce your treatment time and results also. So management of the cases by restorations, and then I shown you the cases previously. So this case is having the 5 years follow up after restoration, and normally it is having a 10 years follow up. So we started case this in 2012. So this the case you can see here, cervical layer, there is a lot of fillings were coming out. So we started with the case for the deprogramming nearly for 3 to 4 years, because patient was from US. And when patient came back, all his symptoms were reduced, and then we started with his full mouth rehab. The patient age is 80 years. So what was the crossbite, canine crossbite was there, is corrected here. This you can see the good occlusion, canine guidance, occlusal view. And this case was done by Emax restoration. Implant is also placed. You can see the good occlusion here. Anterior guidance is there, canine guidance. It's a beautiful aesthetic view of the patient, the smile of the patient. This is before starting. This is stage drive. This is done by Dr. Sayogita, and the final restoration. Okay, this is the final. There are no root canals are done. Imagine these are the previously done root canal treated too. So all we have done without the root canal. Then patient was having the TMD, and patient was having the bruxism. Again, the occlusal splint therapy is given for the preventive purpose. Okay, and then the patient again reported to India last year, and we have taken his 5 years follow-up photographs. You can see there are no breakages. Okay, so if you give a proper occlusion, so nothing is going to happen. And the TMD cases or bruxism, patient having bruxers, the occlusal splint therapy will prevent the breakages of the restoration. This is in 2012, 18, and 22. You can see the patient smiling face. So this is the latest one, OPG of the patient. The case 2, I told you here again, it was a TMD case after deprogramming. We had done the FMR again, the conservative way. The Impress CAD is done here. Then this case after deprogramming, I restore the case nearly class 1. So it was a class 3. You can see H to H bite, but it's good. Still, it is 4 years done. Patient smile. So deep bite case again managed with the implants and the full mouth rehab by me. Okay. Take home finds. So what we should examine in all the patient, this patient, you need to go for a checklist in all the cases. First, examination of the TMJ. TMJ is stable or not. So I shown you all the methods to for examination of the TMJ, like muscle of mastication, intra-auricular method. There should be no deviation, deflection, and the clicking sound in the joint, crepitus in the joint. So if these things are not there, there's a healthy TMJ. Then occlusion, you need to check for normal occlusal contacts, anterior canine guidance, occlusal curves, occlusal interference should not be there into the patient occlusion, muscles of mastication, and neck and back muscles examinations. So before ortho and aesthetic or FMR implant cases, thorough examination of TMJ and occlusal examination is compulsory. Proper treatment planning is important. Healthy and stable TMJ should not have clicking, crepitus, deviation, deflection, and TMJ can be made healthy by using the occlusal splint therapy. If the patient doesn't want to make definitive changes for stable occlusion, he can use the occlusal splint therapy throughout his life with a interval of the deprogramming. So recall of the deprogramming. Sorry, reprogramming. So say no to the soft splint. Most of the dentists or general practitioner, they are using the soft splint, but soft splint doesn't help the patient much. A hard vacuum sheet splint suck on down on the model without anterior canine guidance. Again, you are giving the जैसे थे occlusion. मतलब जो occlusion patient का है interference वाला वही आप दे रहे हो. Doesn't help the patient. So I strictly don't promote this splint and anterior deprogrammer given only for a diagnosis, not for a treatment. So it should be given less than 7 days. So if long-term use of anterior deprogrammer, it what will happen? The covered teeth will intrude and non-covered teeth will be supra-erupted. So I is my request to everyone, please use 40 micron Bosch articulating paper with Miller articulating force in your practice to give good occlusion to the patient. And I would like to thank all my teachers, stalwarts, and seniors of dentistry for sharing their knowledge. Because of them, we are upgrading ourselves. So thank you. So I would like to thank ICPA and Dr. Raju Chittugupi for this invitation and for this opportunity. Thank you.
Thank you for this wonderful lecture, Avinash. You covered the entire breadth of the topic you wanted to cover. And I think you took about 45 minutes, but it was amazing.
Thank
And
you.
let us start with the questions sent to us by the registered participants. The first question is, what are the basic essentials or the must-haves, instruments and equipments for TMD management in general dentistry setup? Somebody is having a general dentistry practice. What are the most essential things for him to start with TMD?
Okay, it's very good question. So why basic? Because first thing we need to have a knowledge of diagnosis of the TMJ is very important. Once you diagnose, the treatment becomes easy. So in your clinical practice, uh, with the help, just for I told you everything about the how to go for a diagnosis. Okay, so clinical examination and of the muscles, TMJ. So with the help of that, you can easily diagnose temporomandibular joint. You can check the occlusion, and if you feel there is a problem with the occlusion, there are interferences. So, and what is your diagnosis? Suppose it is diagnosis MPDS, internal disarrangement, or it is osteoarthritis. So our first aim is stabilize the temporomandibular joint. So we cannot touch the temporomandibular joint by non-surgical way. or with other things. So we in our hand we just have a occlusion. So with the help of by helping the or by stabilizing the occlusion, we can stabilize the muscles and the TMJ. So basically what you need to have in your practice first is the clinical skill to diagnose the TMD. Second, you can use and give a for diagnosis. You can give anterior deprogrammer, or you can make intraoral splint, vacuum form splint, and you can with the help of acrylic resin, you can make intraoral splint. If you have a semi-adjustable articulator, so you can take upper and lower impression, face bow, and by it you mount it. You make a wax pattern and send to the lab. Okay, so basically, if you have an articulator or you don't have an articulator, you still can manage to treat the TMJ with the help of the good diagnosing skill and with the help of the full coverage occlusal splint therapy.
Okay, so good clinical skill, diagnostic ability is the first thing.
Yes,
Then anterior deprogrammer, and the third one is splint. These are the three
yes.
things that are required.
Yeah, because what happened, Dr. Raju, what happened, many people, what they do, they don't properly diagnose the disease and they don't give a proper splint. So that's why many people say splint doesn't work. But in my case, in my all the cases, the 99% all the splints works. So we are not God. So one or two cases, you're not, the difficult cases, they're restricted mouth opening and like that, the difficult cases. But non-surgical way, you can do many things. But again, last hopes is always there of the surgery.
Okay. Um, if a general dentist wants to read TMJ disorders on OPG, what are a few good tips?
Okay, so I have told you this very good close mouth OPG. So because some trans or orbital, transpharyngeal, transcranial view, they are taken at the institute level. So first basic view on OPG, close mouth, ask the patient to go for a close mouth OPG. And in that, what you need to see, the first thing you need to see for the joint space, radiographic joint space. Suppose at one side radiographic joint space is reduced, that means disc is displaced. Okay, and suppose on other side the radiographic joint space is increased, so there the displaced disc, due to that the swelling in the joint is there, or displaced disc is folded, so that's why that joint space is increased. Okay, so reduced joint space will suggest you of the osteoarthritis also. Increased joint space will suggest you of the disc displacement. Again, the radiographic changes like a flattening is there, or you can say some changes like the erosions, so that are
Okay.
suggestive of the again the radiographic changes like osteoarthritis. So this way you can
Which is the
read the
easiest? Which is the easiest? Joint space increase and reduction for a
so
general dentist to
yes,
see on the OPG.
reduced joint space is suggestive of complete displacement of the disc, complete, and
Okay.
it is again the it is what the initiation of, you can say, osteoarthritis.
Okay. So even if general dentist is able to identify these things on the OPG, it is good enough.
Yeah, it
Joint
is good.
space.
And then
Okay.
if they further want, they can send the patient for CBCT, they can
Yeah,
send
yeah.
the
No,
for
no, no.
patient for
No, we
MRI.
just want to know if there is a basic dentist, a fresher, if he wants to start off his journey in TMD, he can start with OPG and he can start with
Yes, yes, sure,
reduction in
sure.
joint space.
Because in
Yeah.
my study, when I done a study 2001 to 4 in GDC, so 100 cases I done the OPG, and from that I evaluated. I cases taken 30 cases from that. So my
Okay.
basis of that sending for CT that time was the OPG only. So OPG is very good radiograph.
Okay.
A
Okay.
TMJ view on OPG is also there.
Okay. Next question. Do all TMJ TMDs diagnosed cases need third molar extractions? Because many a times we see that third molars are the main culprits in initiating TMJ problems or TMD.
Okay, Raju, this is very brilliant question. Those who have asked, because I told in the occlusion, this occlusal curve P. Suppose curve P, I told in the presentation also. If the curve P is very stiff, means suppose the third molar is at higher level, when patient do a protrusive movement, that time the lower third molar may cause the interference, and that interference is closer to the TMJ, and that gives a immense force and torque to the TMJ, and that is again a cause of TMDs.
Okay.
So
Okay.
if the third molar is interfering, it is the cause. But if the third molar is not erupted, is
Okay.
in a infraocclusion, so it is not the cause.
Mhm. Okay. So that question was from Dr. Manjari Joshi from Vadodara.
Okay, very good question.
Okay,
Brilliant dentist.
great. So let us move to the next question. Steps in diagnosing TMD. I think you covered that.
Yes, yes.
What is the best exercise for TMDs if somebody wants to do some?
Actually, yes. In a painful, if the TMJ is painful, you should not advise patient any exercises.
Hmm.
But if there is a laxity of the joint and you make to joint ligament strong, then there are the isokinetic exercises. So what you do in that isokinetic exercises, you take your ask the patient to take the palm and put below the chin, and ask the patient to open the mouth, and with the palm you resist that movement of the joint, so 5 to 10 millimeters like this. It will help to strengthen the ligaments of the joint or the capsule of the joint. But mostly it is helpful in case of if the patient is having a dislocation, or the ligaments are laxing. So
So
that time,
you are trying to open against resistance.
yeah, against resistance,
Okay.
you ask the patient to open it, and then you resist the movement. So this
Okay.
will give a force here. So, but you should
Okay.
not do this exercise in a painful joint.
Okay. Okay. So next question is, what should a practitioner know about pivot splints? Pivot
Pardon?
splints.
Pivot.
Pivot splints. Pivot splints.
Pivot splints. Okay. So there are various types of splint, like anterior deprogrammer splints are there. So there are anterior repositioning splints are there, stabilization splints are there. Same or pivots type of splints are there. They are used in case of this displacement. But according to the review of literature, the stabilization splint are supposed to be the best splint, and pure splints, they are used to recapture the disc. But if they are not properly made, or if the patient is not reporting to you for the recall, then many problems may happen. So in my practice, I normally do and recommend to use of full coverage splint or full coverage stabilization splint.
Okay. Okay. So there is one more question. I think you have covered this. Should we give night guards or not?
So basically, if the in the dentist mind, night guard is a soft night guard, so I say no to them. If they say night guard is like a hard vacuum form, I again say no to it, because you are creating the same occlusion, means same interference you are giving to the patient. So you are not
Hmm.
stabilizing the muscle and the joint. Okay, so best way to give patient is a full coverage occlusal splint with a good contacts, occlusal contacts, and giving anterior and canine guidance in that. The vacuum
Okay.
form tray we give to the patient, again it have a lot of interference, but patient's problems won't be solved in that. So I don't advise to give a soft night guard and hard vacuum form splint in case of TMD cases.
Okay. Next question. What is your suggestion for dental centers in government setups with low resources and low socioeconomic conditions if they want to include TMD management in their practice in those centers within limited resources? How they can start?
Yeah, I already answered this question. So those who want to, first they have a clinical skill to diagnose it. Second, in the government centers already there are the medical hospital is there, or physiotherapy centers are there. There they can send a patient for physiotherapy like TENS, SWD, and in the government centers, full coverage sprint is a big thing, but at least they can diagnose with the help of anterior deprogrammer. So anterior deprogrammer we can make with a pattern resin instantly in 20 minutes, and you can give it to patient for 7 days. So it will help them to diagnose the problem, as well as it will give some relief to the patient. And medicine they can use muscle relaxant they can
Yeah, the
use.
next question is that only which medicines through pharmacotherapy?
Okay, so normally if the patient is having the muscle pain or muscle spasm is there, normally we prescribe the muscle relaxant with the chlorzoxazone and ibuprofen like Flexon MR, or with the diclofenac combination is there with the antacid. Antacid should be given, and when you are prescribing this muscle relaxant to the patient, uh,
Mhm.
ask them not to drive, because this they could slightly cause dizziness or run the heavy machineries. Okay, so they slightly cause dizziness. And other medication, there are many medications, but this simple way is good. And second is that you can ask the patient for go for moist heat fomentation. So steam
Mhm.
towels can be used to apply on the sore muscles or spasmodic muscle, so they are again help to relieve the muscle pain as well as the spasm.
Okay. Last two questions. What precautions should we take regarding implant prosthetics and TMJ, especially in terms of delayed implant placement after 3 4 years of edentullism?
Okay, it's very good question. There was a lecture of mine at the National ISI conference at Nagpur on this only. So I told you we are treating the masticatory apparatus, and in that masticatory apparatus, if the suppose the patient is edentulous for long period of time, so what the patient does? Patient take the mandible forward to chew it. So the patient mandible is habituated to come to that position. The things which do in case of dentures, while giving the dentures, what we do, so we take the mandible back. Okay, and then we give a in a that relation we give a dentures to the teeth. The same way, if the patient is edentulous for a longer period of time, so it is very important first to stabilize the temporomandibular joint. So if
Okay.
the patient really having the TMDs, clicking or painful or sore joint, so I recommend to give a long term temporaries, fixed temporaries on the implants. So once everything is stable, patient, otherwise what happen after giving a final restoration, patient either, I have many referrals from many implantologists. After giving the final process, patients start with the pain, but what happened, they have a pre-existed TMD.
Okay.
So in such cases, I think long-term temperature is both the jaw, at least to the one jaw, and we can adjust the occlusion. Once everything is stabilized, then you proceed for the final restorations. This is my recommendation.
Okay. There is one more question. With an increasing use of aligners, patients start using aligners. They find it very, very non-invasive. There are no braces, there are no wires, everything is comfortable. But after a few sets of trays, then they realize some pain has started
Okay.
in the joints. What could be the reason?
Okay, so very good question. So first contraindication in aligners is, they say, aligners people, they say first check for the TMDs. Okay, so I told you all the tips how to check for the TMJ, clinical and the radiographic. So clinical way, you need to check for the muscles, any click in the joint, and radiographically you need to take the closed mouth OPG. So if pre treatment, if you doesn't feel any TMDs, then you can easily proceed for the further treatment with the deprogramming. Okay, but
Okay.
if the patient is having a pre-existing TMD, then when you start the treatment, there is again uh, TMJ muscles become unstable and the problem will start. So my sincere request to all the people who are doing this treatment, even the ortho treatments, or first you examine the TMJ properly, and a slight deprogram is required in all the cases, and after that you start the treatment. So then there will be less problem you'll face in the your treatment plan.
Great, great. Now the last question. If we get a mild clicking case,
Okay.
what should be our plan of action?
Okay, so I told you, if the clicking maybe it is not like a, we say mild clicking, we say initial click, mid click, and late click. So click, the patient gives a click. So I shown you the video. Why do we get a click? Click means this is displaced anteriorly. So
Mhm.
the clicking, if you palpate or hear, so what is the diagnosis? It's the disc displacement with reduction. So if the patient is having that, you need to check for occlusion of the patient, and better to stabilize the joint with the help of full coverage occlusal splint. So
Okay.
in early cases, young cases, click may go depending on the location of the click, sorry, disc, and the click also you get the result. So if the click is very late click, so like a late opening, so prognosis is not so good. Early click treatment is good, or you can
Okay.
say good results in that cases.
Okay. If the patient is a kid of 14 to 17 years with clicking present and
Okay.
also needs orthodontics, should we treat clicks first and then go for braces or vice versa?
No, if you know the patient is having TMD, so better you treat the TMD first, because with the treating the TMD, you are stabilizing the TMJ and the muscle.
Okay.
Because what happened when you do the orthodontics, normally when there is an abnormal occlusion, we do the orthodontics. So due to abnormal occlusion, there is an unstable TMJ. So if you directly treat the orthodontics, treating the occlusion without treating the TMJ, what will happen? Once the TMJ occlusion is stabilized, again what will happen? That time TMJ wants to get stabilized, and that time again the shift of occlusion will happen. So I have 3 4 cases where the orthodontist treated it, and after 4 5 years they find it open bite. So if you first stabilize the TMJ, like we can say centric relation, and after that you stabilize the occlusion by orthodontics, it is a good way of treating these cases. Otherwise, you again need to treat the click and again need to treat the occlusion. So I had done few cases like that. Even after orthodontics, there was again orthodont do the re-ortho treatment because there was an unstable TMJ. So again, I have done the occlusal splint therapy in such cases, stabilize the occlusion and then the ortho.
Okay. Next question. What produces the clicking sound in TMD? Is it the articular disc movement? Then why is it abnormal? All clicking sounds are not pathological.
Yeah, so I told you why do get a click in the joint. So click the when the disc is displaced the anteriorly when you open the mouth head of condyles. So what will happen in the normal video I shown you the disc and the head of condyle are moving together. But in case of this displacement with reduction, so the disc is displaced anteriorly, and when the patient opens the mouth, the head of condyle hits the disc during opening. That is opening click, and during closing it is again going hitting and going back. So that's why you get a click. So in that the disc is displaced anteriorly. So suppose the click is normal, then normal we say slip disc also, cervical slip disc, that should be also normal. So if it is normal, then every person should have a click, because
Hmm.
normal will be in everyone. So it click in the joint is not normal, it is a pathology.
Okay. Okay. What about popping sounds? Why does it
Uh,
happen?
Popping and clicking sound are nearly same. They are the
Okay.
same sound. So just hearing this click and pop like that, but it is a click like sound.
Okay. So that brings us to the end of the session. Thank you, Dr. Avinash Kshar, for covering almost all the aspects of TMJ and TMD and answering all the questions, those sent by the registered delegates as well as the live questions. It was a wonderful session. And those who want to know more about it, some of the concepts are complex. I suggest all of you to go back to the ICPA YouTube channel and watch the recorded video. And soon we'll be sending the 5 point summary of this lecture along with the recorded lecture link. And if you're following the Facebook page of ICPA, you can watch the recorded lecture there itself. So you got ICPA Facebook page as well as YouTube channel. So once again, my heartfelt thanks to Dr. Avinash Kshar. I wish you all the best in your continued research in TMJ and TMD. May you come up with many more findings and many more research projects. Thank you. And all the viewers, soon will be announcing our next episode, episode number 27, a new topic, but the theme remains the same. Each episode, one clinical challenge. So thank you once again, and a very good night to all of you.
Thank you, Raju. Thank you, ICP.
Thank you, Avinash.
Thank you. Good night, everyone.